Thank you very much for inviting me here. I do not have any conflict of interest to declare. And I'd be happy to present our first results from INCAB's imaging study. Bipolar disorder is a highly debilitating psychiatric illness that affects 1 to 3% of the adult population worldwide. As it was said already today, BD is commonly occurring in adolescents and causing emotional and behavioral problems that can lead to psychosocial dysfunction, substance abuse, and suicide. Objective neural markers are needed to both reveal BD in its early stages and distinguish it from other forms of psychopathology and comorbid disorders. Verbal recall dysfunction is common in individuals with psychopathology and may be associated with neural abnormalities in structure and function. Verbal working memory impairment is observed in mood disorders and has the potential to be a cognitive marker of bipolar disorder. Identification of specific abnormalities in structure and function among inpatient participants can inform our understanding of verbal working memory recall dysfunction and suggest treatment targets. I would first like to stress the nature of the sample we will be discussing. All participants in this study, in this analysis, are psychiatric inpatients between the ages 13 and 17. They were hospitalized due to the severity of their symptoms and participated in this study during their inpatient stays. This is an ongoing study. We are currently in third year. Bipolar disorder group included 18 participants, and our psychopathology group included 33 participants with major depressive disorder, anxiety disorder, ADHD, PTSD, and conduct disorders. A multimodal approach was used, including functional magnetic resonance imaging, diffusion tensor imaging, and gray matter analysis, along with clinical and cognitive measures. For fMRI, we employed an event-related card guessing game adapted from previous studies to examine neural activity during anticipation of monetary reward. The outcome could be win, loss, or no change. For this study, we focused on the uncertainty-related component of reward anticipation. The experience of uncertainty about whatever a win or loss will follow is particularly important for youth with emotional dysregulation and mood swings, because this experience actually commonly occurs in real life and may affect severely such people with such problems and disorders. The fMRI data were processed using SPM12, and we conducted a whole brain one sample t-test for combined BD and OP group. White matter tracts were segmented in native space using TractSeg, which employs a convolutional neural network-based approach to automatically segment 50 major white matter tracts. After accurate reconstruction of the tracts, the main DMRI metric of interest, a fractional anisotropy, an indirect measure of fiber collinearity in white matter tracts, was extracted in 98 nodes along each tract and then averaged across the entire tract and exported into statistical software for further analysis. Structural scans were processed using FreeSurfer. The whole brain cortical volumes and thickness were normalized to account for head size differences and then transferred to statistical software. The free recall stage of the verbal recognition memory task within CAMH package was used to assess verbal working memory. Participants were shown words one by one and were asked to repeat them loudly and memorize. In free recall stage, immediately after the presentation of 18 words, they were asked to recall and say to the examiner as many words as we could. To identify the most relevant variables for each modality of interest, we used a penalized regression elastic net model for variable selection, employing the GLMNet package in R. This approach was applied separately for each of the 4 modalities: gray matter volumes and thickness, white matter tracts, and functional activities independent variables, with verbal working memory recall as the dependent variable. ElasticNet is a modified form of least squares regression that penalizes complex models with a regularization parameter, and it is very important, is sensitive to correlated variables. We used threefold cross-validation with an ElasticNet alpha to identify the optimal penalty term that minimized mean cross-validated error and reduced the chances of overfitting. Multiple regression models, one for each modality, were used to quantify effect sizes and the extent to which each identified non-zero variable from previous step was associated with verbal working memory. To account for multiple comparisons, we applied a false discovery rate correction by Benjamini and Hochberg. To explore the nature of the relationships between different modalities, we performed mediation analysis using the process macro bootstrapping algorithm. We tested separate mediation models for each significant structural variable from previous step as an independent variable and functional activity as the dependent variable, with verbal working memory recall as the mediator in each model. The selection of this mediator was motivated by intention to investigate how a cognitively demanding task affects the relationship between brain structure and functional activity associated with uncertainty. Analysis were shown the negative relationships between verbal working memory recall and neural activity associated with uncertainty in the left angular gyrus. A considerable body of literature has implicated the angular gyrus in several cognitive processes, including verbal working memory and semantic memory. We also have found negative relationship between verbal working memory recall and left posterior cingulate cortical thickness, which is a key-node of default mode network. It was reported that PCC may mediate interactions of emotional and memory-related processes. Analysis also revealed the positive relationship between verbal working memory recall and left pericalcarine cortical volume. The recent paper linked decreased volume in these regions to psychosis risk. Analysis also have shown the negative relationship between verbal working memory recall and right striatal frontal orbital tract, a neural pathway connecting prefrontal cortical areas with subcortical striatum and involved in executive functioning. This slide shows the results of mediation analysis. A highly demanding cognitive verbal working memory recall task mediates the association between brain structure and function. The direct effect C prime represents the relationship between left posterior cingulate cortical thickness and uncertainty-related activity in the left angular gyrus after mediator inclusion. The indirect effect denotes the mediation effect of verbal working memory recall on the relationship between gray matter and functional activity. The A path indicates the association between gray matter and verbal working memory recall, and B path reflects the relationship between verbal working memory recall and functional activity. The results suggest that verbal working memory recall mediates the relationships between the thickness of PCC within default mode network and uncertainty-related functional activity in the left angular gyrus, the part of central executive network. The exploratory analysis revealed that the volume of the left pericalcarine was significantly associated with verbal working memory recall in the OP, but not in the BD group. Conversely, the functional activity in the left angular gyrus was significantly associated with verbal working memory recall in BD, but not in OP. The relationship between the thickness of the left PCC and verbal working memory recall was significant in both groups, but more prominent in BD, blue line, Then in OP green line, the left graph. The additional exploratory analysis included a comparison with healthy controls, right graph, and the magnitude of relationships between left posterior cingulate thickness and verbal working memory was similar for OP, green line, and healthy controls, red line, and different for bipolar disorder group, blue line. This is an ongoing study, and we are planning to continue this analysis of larger sample sizes. Our results suggest that the highly demanding cognitive process, such as verbal memory, may influence the relationship between cortical thickness in the default mode network and uncertainty-related activity in central executive network in these severely ill inpatient adolescents. This may suggest a lack of cortical thinning during adolescent development and executive functioning challenges when reward and loss is uncertain. Our results also show that the distinctive patterns of association between verbal working memory and brain structure and function may be used to differentiate bipolar disorder from other forms of psychopathology. Overall, our findings demonstrate that all modalities of interest, including structural measurements and functional activity, help us to understand the patterns of verbal working memory recall in adolescents diagnosed with bipolar disorder and other forms of psychopathology. Thank you very much for your attention. Any questions?
Do we have any questions? Dr. Fedorov?
Yeah, I was wondering if you go back to the slide with the mediation model.
Yep.
I'm just wondering what led to specify the model that way. So, I mean, ultimately the mediator is an intermediate to causal pathway, right? So we're assuming that this changes this, which in turn changes this. And I was wondering, why did you go in that way instead of maybe flipping these around in different directions? So, for instance, verbal working memory being the outcome, and then the functional activity being the mediator, or something like that. So, just be interested in your group's thoughts on how you specified it the way that you did.
Yeah, that's a great question. Actually, both verbal working memory task and uncertainty in reward anticipation were functional tasks. Only one was like purely cognitive infant contact package, and other was fMRI. So the idea was that those relationship between brain structure and uncertainty-related function might be influenced by highly demanding cognitive task. So we were interested to see if people with like severely ill inpatient kids, what happens with those relationships if they are asked to perform this highly demanding cognitive task. So that was the aim of this particular mediation analysis.
Great. Is there any other questions? There's no online questions, so thank you for your presentation. Sorry about the delay, everyone. So I'm pleased to introduce our second speaker for the rapid oral presentation. Dr. Georgina Hosang is an associate professor at the Goldstein Institute of Population Health in Queen Mary University of London. Her interdisciplinary work focuses on impact of life stress, such as childhood trauma and recent life events, on the onset and course, including physical health outcomes of bipolar disorder and depression. Additionally, she is also interested in the developmental pathway from adolescent hypomania and bipolar disorder using twin data. She is the co-chair of the Early and Mid-Career Committee of the ISBD, which is the International Society for Bipolar Disorders. Thank you.
So I just wanted to say it's an absolutely fantastic way to mark World Bipolar Day. So it's so wonderful to see you all. I just wanted to thank Dr. Goldstein and colleagues for coordinating and arranging the day. And it's wonderful to speak to you all. So I'll be speaking to you today about the etiological overlap between adolescent hypomanic symptoms and bipolar disorder. I have no conflicts of interest to declare. I was told I needed to outline some learning objectives. So by the end of this session, hopefully you will be familiar with the phenotypic continuum model and how that relates to bipolar disorder. And secondly, to gain a better understanding of the relationship between non-clinical hypomanic symptoms and bipolar disorder. So, broadly speaking, in psychiatry, we're all interested in the etiology and developmental pathway of mental illnesses. And one of the most powerful approaches to answer and tackle these issues is to use large community longitudinal studies that have prospective and multiple assessment. But because of the low prevalence of bipolar disorder, we often can't use these approaches. So what we tend to focus on when it comes to longitudinal designs is to look at high-risk populations. So today we've heard a lot of results from a suite of child offspring studies. But another approach is to look at those who are at high risk based on the symptoms that they experience. So this is really drawing on the phenotypic continuum or symptom dimension of psychopathology. So this is used widely in psychiatry. So the premise is that psychopathological symptoms such as depression, anxiety, and in our case, hypomanic symptoms are experienced within the general population. But those at the extreme end are the individuals who require clinical attention and have a diagnosis we think of like bipolar disorder or depression. And then you have those at the top end who we would consider at high risk of developing a disorder. So looking at hypomanic symptoms in youth, there are a number of advantages. So it's more specific to bipolar disorder, whereas if you were looking at depressive symptoms, that might be mapping onto bipolar disorder or depression. It's more common, hypomanic symptoms are more common than clinical bipolar disorder. And when we're examining hypomanic symptoms in the general population, we can look at the phenomenology, etiology, and risk pathways prior to medication use and the onset of the illness. But questions remain about the validity of using hypomanic symptoms in terms of it representing a symptom dimension or phenotypic continuum of bipolar disorder. So for us to really look at the validity of using this approach, we can look at two separate issues. So one is, how does hypomanic symptoms relate to bipolar disorder? Secondly is looking at the genetic and environmental overlap between hypomanic symptoms in non-clinical populations and bipolar disorder. So in our study, we attempted to tackle some of these questions, and we had three broad aims. So firstly, we wanted to look at the relationship between hypomanic symptoms at age 18 and bipolar disorder diagnosis up to age 24. Secondly, we wanted to look at the genetic and environmental overlap between hypomanic symptoms at age 18 and bipolar disorder diagnosis. And then finally, to examine the association between hypomanic symptoms and the polygenic risk scores for three disorders. That was bipolar disorder, schizophrenia, and major depressive disorder. Although I'll present our key findings in this presentation, if you did want to read in more detail, we published these results in JAMA Psychiatry in 2022, so you can look at it in more detail if you wish. So we use data from the child and adolescent twin study in Sweden, affectionately referred to as CATS. And this is a large longitudinal study where participants entered the study at age 9 to 12, and they're followed up to age 18. And we've got data on 8,568 twin pairs. The parents completed the mood disorder questionnaire, and that's how we got our measures of hypomanic symptoms. And then based on the number of symptoms that clustered at the same time and caused moderate to severe impairment, we were able to identify a high risk group. The bipolar disorder diagnosis was taken from official records, so population registers in Sweden. So you've got the diagnosis taken from the Swedish National Patient Register and prescription of lithium, which is the predominantly used to treat bipolar disorder in Sweden, from the prescribed drug register. I should highlight that we've got data up to age 24, and that's because that was the age of the participants at the time of our study. So in this particular study, we use twin data, and it's a natural experiment. We're able to take advantage of the fact that we have two types of twins. So we have identical twins or monozygotic twins that share 100% of their genetic makeup. And we also have non-identical or dizygotic twins that share approximately 50% of their genes. So what we're able to do is contrast the twin correlations between the identicals and monozygotic twins and dizygotic twins, and we can estimate three parameters. So these are A, C, and E. So A is our heritability, and this covers both rare and common genetic variants. C refers to the shared environmental influences, so those environmental factors that are common between the twins. And then finally, we have E, which is our non-shared environmental influences, so those environmental influences which are unique to each twin. So we were interested in the genetic and environmental correlation between bipolar disorder and hypomania, and we analyze this using a bivariate twin model. So what you can see here in our model is that we have the same three parameters, A, C, and E, and they're influencing hypomanic symptoms and bipolar disorder. The arrows I'd like to draw your attention to are the arched arrows at the top, where we have RA, RC, and RE. So these are our genetic correlations and environmental correlations, and they're the ones between hypomanic symptoms and bipolar disorder. So moving on to our results. So if I go back to our first aim, we wanted to look at the relationship between hypomanic symptoms and bipolar disorder. So first we found a moderate but significant association between hypomanic symptoms and bipolar disorder diagnosis at age 24. And when we looked at the high risk group based on the hypomanic symptoms, they had a higher odds of having a bipolar disorder diagnosis. I think it's helpful to look at the literature in terms of depression, because this approach, the phenotypic continuum or symptom dimension, is so widely used for depression. And what we can see is that our results are very similar in terms of range to what we see for depression in the same sample. So this is where we're looking at the genetic and environmental correlation between hypomanic symptoms and bipolar disorder. So the first thing that I'd like to draw your attention to is that this is an AE model. So the common environmental factors or influences, they played a negligible role in hypomanic symptoms and bipolar disorder. So we've only got these two parameters. And if we focused on the arched arrows, we can see that we have a genetic correlation of 0.4 and a non-shared environmental correlation of 0.41. So these are moderate but significant correlations. And again, if we look at the results for depression in the same sample, these results are within a similar range of what we see for depression and how it relates to major depressive disorder. So our final aim was to look at the association between hypomanic symptoms and the PRSs for bipolar disorder, schizophrenia, and major depressive disorder. So in the first column, we have the PRSs. In the second section of this table is the hypomanic symptoms, so a continuous variable. And then in the last section of the table is the high risk group for bipolar disorder. And interestingly, the only significant associations we found were for hypomanic symptoms and the PRS for schizophrenia and major depressive disorder, not bipolar disorder. So in sum, we found that hypomanic symptoms were significantly associated with bipolar disorder diagnosis. We found moderate genetic and non-shared environmental correlations between hypomanic symptoms and bipolar disorder. And hypomanic symptoms were significantly associated with the schizophrenia and major depressive disorder PRS, but not the bipolar disorder PRS. So for me, the most curious finding was the fact that we didn't find an association between hypomanic symptoms and the bipolar disorder PRS. And we've been, looking at the literature and trying to kind of grapple with that finding. And what's interesting is that these findings are consistent with other studies. So those that look at, for example, ALSPAC, so that's a community cohort study in the UK, they also don't find a significant association between non-clinical hypomanic symptoms and the bipolar disorder PRS. We're not really sure why we don't see it. And one thing to consider is that the bipolar disorder PRS only explains kind of a small to moderate proportion of the bipolar disorder genetic variants. And it does focus on common genetic variants. So is the association genetic correlation between bipolar disorder and hypomanic symptoms more focused on kind of rarer genetic variants? Something to explore. And I think future studies might want to consider that. Going back to thinking about hypomanic symptoms in non-clinical populations and whether it represents a phenotypic continuum, it seems that we're providing some support and evidence for this. But as we've heard today, particularly from Rudolph's talk, there are a number of different symptoms that we might need to be thinking about when we're building a kind of a model, phenotypical symptom dimension model of bipolar disorder. So we know clinically that people with bipolar disorder experience depression and psychosis. So we might want to consider those symptoms within a symptom dimension. As Rudolph's highlighted, anxiety, ADHD, there are other things that we might want to think about. So the take-home message is there's lots more work to be done in this area. And I just want to end with this. I think I've been doing a lot of work looking at the symptom dimension of bipolar disorder. Can we use hypomanic symptoms? But one of the kind of byproducts of our research shows that actually studying hypomanic symptoms in non-clinical populations is important in its own right. It's associated with reduced life satisfaction, with sleep problems, as well as other forms of psychopathology. So I think it's more research in this space is warranted. So all I've got left to do is to thank my collaborators. I'd also like to thank the research teams, but especially the participants for their time and their efforts. Thank you for your attention.
Great presentation. Is there any questions from the audience? Dr. Goldstein, I'll let you start.
If you look at hypomanic symptoms, as a cluster, but as distinct symptoms in the patient or something like that, the way in
We didn't look at that, but that's a really good question. We didn't look at that, but that's something that we could do. Yeah, that's actually a really good question. Yeah, thank you. So we looked at in this sample, let's see if I've got it here. So in this sample, this is one of the first studies that we did, is that we thought that everyone's going to ask this question, are you just not measuring ADHD? So what we did is we looked at the overlap between the two. And essentially what you see, if you look at the shared genetic and environmental influences on ADHD and bipolar disorder, they don't explain the whole variance. And actually you see significant proportion of the hypomanic variance, which is distinct, it's unique to hypomania. So yes, they were correlated, but I don't think it's just ADHD. There was definitely something that was specific and separate from ADHD. I'm looking at you, Rudolph.
It's one observation is right, like this reasoning why the bipolar polygene would not be associated, right? Any of the possibilities, like perhaps it's just common variants, that they would also translate to the schizophrenia and depression.
Right, exactly.
And those were associated.
Yes.
So for me, that's like a really interesting clue there.
Yeah.
And obviously, anyone who I don't know if it's used for the same purpose in UK, but here we all hate hypomania checklists because we keep getting the family doctors referrals that we see this person with this hypomania checklist, and it's never happening. So it's you get this reaction to that. I wanted in the study the cats, assuming that there's many other symptomatic measures, and that I would be, and many psychology symptoms will predict late diagnosis of bipolar.
Sure.
And I wonder if you may have the opportunity to check the specificity both ways to perhaps have dimensional measures of depression and anxiety, but also look at the diagnosis of major depressive disorder. Because you see this association between depression and hypomania. And the question is, does that you see that better than?
So one of the things we did look at is we wanted to kind of look at the genetic and environmental overlap between hypomanic symptoms, schizophrenia, and major depression as well. And actually the correlation between hypomanic symptoms and major depressive disorder diagnosis was negligible. It was so small, we couldn't even. Yeah. And what's, I think one of the things I would say about cats that I really like is that we've got the mood disorder questionnaire, which is the preferred over, for example, the HCL. And then we had parent rated symptoms of hypomania. So according to Eric Ljungström's work, that's the preferred one. So that's why, like, I feel like we're really lucky to have this particular data, because most of them are self-report symptoms, but like we still can't get my head around the lack of association with the bipolar disorder PRS. So yeah, maybe I'll pick your brain later. Thank you. Oh, okay, yeah, I can do that. This one? Yeah. You're welcome.
The question relates to some of the others. Not a lot about like hypomania general population that runs with it. Are there other sort of variables in this rich data set that sort of correspond well? I was initially thinking like So just wondering what else, are there other things in the data set that kind of run with this to give us a sense of what we're looking at?
So I've looked at hypomanic symptoms both in cats, but also in a twin study in the UK called TEDS, and a couple of things. So a couple of things is that with hypomanic symptoms, we found that it was associated, I think what we did find an association, I think, with extroversion. Yes.
Okay.
We also find that there's significant correlations with other forms of psychopathology. So your depression, anxiety, psychotic-like experiences, ADHD, and some work that we're currently doing is we're looking at, for example, eating pathology or problems with like eating behaviors. We're also looking at aggression and conduct disorder, etc. And there are correlations, but they're never, they're all moderate associations. So I definitely think there's something distinct about hypomanic symptoms, but it does, and I mean, we see this, don't we, for all forms of psychopathology, is that they tend to be associated. But even when, so we've done a couple of similar studies where we're looking at the genetic and environmental overlap between these other forms of psychopathology, and there is overlap, but it's never at a significantly high level where you think actually you're measuring something else.
Yeah, interesting.
So any other questions? Okay, I think we'll move on to the last speaker of this oral session. So the final presenter for today's oral session is Matthew Carlucci, who's a research methods specialist at CAMH in the Department of Neuroscience Research in the group of Dr. Turis Paternis and epigenetics. Thank you.
All right. Thank you for having me here to talk today about some new work. I was also told there were learning objectives that were to be included here. So this work was done in collaboration with some neuroimaging experts right here at CAMH. And I will discuss some of the connections with circadian biology and affective disorders that have been mentioned earlier today. And I will discuss a novel model of within subject variation in MRI data. This work is all under review currently and should be hopefully published soon. So a typical neuroimaging study that we've seen today could be in the form of a cross-sectional study where there is a kind of a snapshot study where we see the differences between cases and controls. In this case, we see a increased cerebral blood flow in a key brain region. And this is a typical and valuable study that has guided treatments and other research. But we began to wonder whether these static effects might be more dynamic. So for instance, based off of today there have been discussions on sleep and connections to bipolar disorder and other affective disorders, including genetic associations. And altogether, these suggest that there might be some dynamic differences rather than static differences in affective disorders. So we began to consider whether some of these effects that we observe as static snapshots might in fact be changing throughout the day, and what was an increase in cerebral blood flow, for instance, could be a decrease at a different time of day. We searched for any evidence that this is the case, any studies that have looked for these types of rhythmic effects in the brain. We were surprised to find that when we searched for the keywords MRI and diurnal rhythms, circadian rhythms, we did not find too many studies. So the studies that were done demonstrated in principle that there are effects for time of day. There are differences in the morning and evening for the same subject. But these studies tended to be in only a few MRI-derived metrics. They would maybe be at different times of morning and evening, so it's difficult to compare the studies. And we, in general, aim to first fill this gap before moving on to any associations with bipolar disorder. So our study was 16 male subjects, stayed 24 hours at the CAMH imaging facility. So they stayed overnight and were imaged at 9 time points. And this allowed us to model in each individual their daily patterns. This was a large study effort to have subjects stay overnight, so we wanted to maximize the utility here, and we performed many MRI-derived metrics on these subjects. So it would be a 30-minute imaging session per time point where we collected all these 9 metrics. We also measured their body weight, which is known to fluctuate throughout the day and have a peak at midnight. And we were easily able to recreate this finding in these subjects. So we moved on to the MRI metrics with some confidence that our methods are sound.
Attention please, code white, 1051 King Street, level 1, 1905, cancel. Code white,
I'll wait a
1051
bit.
King Street, level 1, 1905, cancel.
Okay, so in cerebral blood flow at the whole brain level, we took whole brain averages for the subjects, and we fit a cosigner model to each subject where we're able to estimate the time of their peak. And you can see on the left here for cerebral blood flow, there's some amount of variation in the models that are fit to each subject and their peak times, which is interesting on its own. But we're also able to establish a significant group level mean oscillation with its peak time at 9 p.m. for cerebral blood flow. You can see on these circular diagrams, the individual dots are individual subjects, and we have them clustering around average times. Similarly, for gray matter mean diffusivity, we saw a peak time around 4 p.m. For white matter mean diffusivity, a peak around 1 p.m. And for white matter fractional anisotropy, peak around 6 p.m. So with these populational models established in our small cohort, we returned to the raw data to better understand their explanatory power in the data. So you can see that there, in the raw data, there are these baseline differences between the subjects in brown, where there's a large variation, and within the subject, there's some variation, and our average model is only able to explain 1% of this total variation. So I wouldn't consider this a negligible amount of variation for designing studies. These should be, time of day should be considered with care. But more importantly, when we remove the subject effects and focus on the within subject variation, we see that this populational average explains 20% of the variation in this metric, which is white matter mean diffusivity. So it's very important to consider time of day, especially for repeated measures on the same individual and looking for differences that this is not driven by a time of day effect. We then moved on to the regional level to partition the brain into individual regions to look for these oscillations, and we were able to detect them across up to 80% of regions for cerebral blood flow. And we saw that the acrophases were fairly uniform across the brain, which was a bit of a surprise. And then for the metric of quantitative T1, which was developed here at CAMH by Dr. Sofia Chavez, and it's a measure of tissue microstructure. We didn't see any synchronous rhythms, any consistent rhythms across the subjects. But then interestingly, we saw that for one subject across the brain, their acrophases were fairly similar. So this led us to believe that these are real rhythms, but it's unclear why they're not consistent across subjects. And again, this variation in phases is quite interesting. So after establishing a better map of diurnal 24-hour effects in controls, we moved on to the bipolar disorder cohort, who were in remission. We had eight subjects who also stayed overnight at the imaging facility and were imaged 8 times at 8 time points. And our goal was to compare them to what we saw in the controls. So for instance, at the whole brain level, whole brain averages, we see in gray matter mean diffusivity that the bipolar disorder group had its own rhythm, and it was very similar to the controls, well within the margin of error. So there was no indication that there was major disruptions in this cohort. Given the small sample size of this kind of study, we explored the combination of the two groups to look for any evidence that there's oscillation in some of those metrics that we didn't see any evidence for. And here we did see that gray matter volume and cortical surface area had some evidence of oscillation. So far from what I've presented, 8 of the 9 MRI metrics that we investigated have some evidence of daily fluctuations. I return now to one of our main metrics of interest, cerebral blood flow, where in the bipolar disorder group, we weren't able to establish any synchronous group level pattern of oscillation. And you can see that the acrophases for individuals are widely dispersed at the top there. And we wondered whether this could have been due to the low sample size of this group, but we tested by permutation testing whether this variation in the acrophases was larger than expected, and it was significant. And further, we connected this to their sleep quality index, which altogether leads us to believe that this is an interesting finding. And with this loss of group level rhythm, there's some dynamic considerations, again, going back to those cross-sectional type studies. If you were to perform a cross-sectional study in this data at 9 a.m., you would see a 2-fold difference in the effect compared to a study performed at 9 p.m. And this presents an interesting consideration for studies going forward. To summarize, we've established a more rich picture of the diurnal 24-hour rhythms in MRI-derived metrics. And it makes it very clear that one should consider time of day. So randomization is a very viable way of doing this, but also controlling directly for time of day, or more importantly, to make sure that this time of day metadata is collected during your studies to improve the reusability of the data as we better understand these effects. Again, connecting back to affective disorders and 24-hour rhythms, we see some interesting differences in our cohort that lead us to believe that these dynamic effects should be considered during cross-sectional studies and other work. In the future, it would be great to get more data. In this study, we weren't able to really compare case control groups at the regional level, which might have had some interesting functional implications, and also to expand to further populations. The feasibility of a study like this, having subjects overnight, could be improved. That, I thank all my co-authors and collaborators and everyone else involved, and would love to accept some questions.
Great presentations. Audience, have any questions?
I have more of a comment than a question. The first comment is a kudos. I think that oftentimes we're designing studies and you're thinking you have a question that comes up that benefits studies on you, try to look through literature to see, oh, are there effects, diurnal effects on, say, this brain imaging measure, for example, your question, and it's just not there.
Yeah.
And so kudos for looking into it. But also the other comment is, damn, like this is a major headache, right? If you're already dealing with scanner schedules, participant schedules, participant reliability, holidays and everything else, and trying to get these studies done. And, I mean, you mentioned at least collecting the data so you can adjust or do something with it. But if you're trying to actually, get people at the same time, like.
Oh, to perform a study, yeah, that's what.
Like the results are disappointing till at some level, right? We'd like to say there's no time effects.
Yeah.
Yeah. Yeah. Again, like randomization is very, very viable for dealing with this effect, as long as it's considered.
Yeah, so you're not bringing all your cases in at one time.
Yes.
So it's fair enough.
Yeah. But yeah, to your point again, like very, very labor intensive and logistically difficult to study.
Dr. Hyphen?
Very interesting work. Can you say a little bit more on how you would recommend adjusting for it though? Because especially, I mean, that's and there is some work on that, about the diurnal rhythms.
Yeah.
But like it wouldn't be time between scans because they might be very similar 12 hours apart, right? So how would you think about adjusting for something like that?
Oh, sure. Can I repeat the question? So I think the question was, for instance, in an fMRI, if you were to, how would you consider these effects when designing your study?
And specifically adjust. You said
specifically adjust.
Yeah.
Yeah. So controlling is a good strategy, like doing all of your scans at the same time. So from the design level, it's not exactly the same time, but randomization again is a way to ensure that you don't confound your effect of interest in the study. But then when I'm talking about collecting the data for later adjustment, it's like if you combine this data later with another database, and you can maybe adjust for this effect once you've collected more data, and in the future when we understand these effects better. Yeah, we need some kind of model to use to adjust it.
Really interesting, and especially finding effects for similar effects on measures that we would typically expect to be more stable, right? The blood flow it's expected, but perhaps with diffusivity or fractional anisotropic less.
Yes.
So it's a bit of a shocker. But I wonder how much you can tell about what is it actually that is causing the changes, because it's unlikely to be the clock time. Right? It may be time since waking up. It may be time since eating. It may be fatigue. It may be daylight.
Yeah.
And I do recall that it is this trying to match, like, let's say, patients and controls on time of the day. Like our patients on average wake up 3 hours later. Controls.
Right.
That's so matching the clock time may not
do
the job. So I wonder how much you know.
Right. Yeah, there's a lot of factors involved here, and like I tried to show at the beginning with that illustration, like there's environmental factors, extrinsic factors, and then there's also intrinsic clocks and chronotypes that are that could be influencing differences, and it's not really clear how to. Maybe this is too unsatisfying, but it's not clear how to account for chronotype in that sense. So we would need a better model for chronotypes.
It's like they like all start in the morning.
They did all start in the morning, and then they go overnight. So there's a slight disruption to their sleep overnight. which is kind of unavoidable in a study like this. And yeah,
Just wondering,
it's
you know, what to do.
right. Yeah, all we can recommend is that you consider what effects these might have in your day. Yeah.
People with bipolar, they have sleeping disorders. They don't sleep enough at night, but
Yeah.
they have naps during the day.
Right.
So my the concentration level.
Yeah. Yeah. So all of these are kind of they're present, right? They're present in what we're observing, and it captures everything that happens throughout the day. So again, it's
My afternoon appointments are taken 3 more weeks in advance in my morning appointments because people are not.
okay.
Playing their big number.
Okay. Interesting.
Thank you. Increasing aspects to the extent of the doing biomarkers should actually take the samples in the morning, but also here when you look at the biomarkers all of them at nighttime. Starting even at the complement, the cancer, looking at other like minimal with the lymphatic system that seems like the not having in the night time. So it would be nice to have them sleeping in these cabins. But
Yeah.
one thing about this difference is maybe describe any medication.
Yeah, absolutely. So they do have medications. They are they tends to be difficult. Yeah. Well, yeah, that would absolutely.
Are there any other questions? All right, thank you, Matthew.
Yeah, thank you.
So thanks everybody for sticking with us this whole day. It's been a dense curriculum, if you will, but we've had a lot of people in person that have stuck around. I think online it's been the same thing. A lot of comments from people having coffee and chatting about interest in this topic. So we're really grateful to you for coming and bringing meaning to this event, asking your great questions. We're also grateful to our speakers who fielded the questions really well, and I think did a fantastic job to a person in conveying the importance, the rationale behind what they did, and the implications that there are for future generations and for people affected by bipolar disorder today. So please consider this a placeholder in your calendar every March 30th, and join us again next year. And if you have ideas about ways to build on what we do here, please reach out, youth.bipolar@camh.ca, and we'll be keen to try to incorporate topics, methodologies, even suggestions for speakers. So thank you and have a great rest of your day.